As you heard from the introduction, I'm actually a gynecologist, and it seems strange probably that a gynecologist would be concerned about bone health. But I got into this a long time ago when I was a medical student, and I was exposed to a researcher who was very interested in this topic, really before anybody else was. This was at Washington University in St. Louis. So I kept that interest, and then in my practice, I have a lot of postmenopausal patients. And what I've been seeing is, for the last few years, that a lot of women would have a hip fracture, and they would have their hip fracture fixed, but no one would ever address their osteoporosis. Their osteoporosis would go untreated. And nationwide, this is a huge problem, and it's been calculated that less than 20% of women who have a hip fracture are ever treated for osteoporosis. That's something we want to change. So the whole problem that we are addressing, we're talking about postmenopausal osteoporosis in particular, the whole problem stems from loss of hormone at menopause. And menopause is the time when a woman's periods stop. If that happens naturally, it's around 50 to 52 years of age. Periods dwindle off and stop, and a lot of women either aren't or don't want to take hormone therapy because they're concerned about it. So when hormone levels drop in the body, then there are cells in the bone called osteoclasts, and those cells actually take the bone apart, and bone density is then lost. So a postmenopausal woman can lose 7 to 10% of her bone density in a 3-year time interval, and that can be really significant. How many people in this room have had a bone density test? Wow, so most people, looks like, have, and that's really good. Because all women should have a bone density test by the age of 65, and all men should have it done by the age of 70. That doesn't mean you should wait till you're 65 to have the test. What it means is that at menopause, you ought to start considering it. Your doctor should be considering it. And then if you have risk factors, the test should be done a lot sooner than age 65. The main risk factors are a personal history of a fracture, like not when you were 10 years old, like falling out of a treehouse, but if you're an adult and you slip and fall and you break something, that's a risk factor. If your mother broke her hip, that's a big risk factor. And if you're on steroid medications, or if you smoke cigarettes, those are all risk factors we're really concerned about. So all of you who've had this done know this, but a bone density test is not invasive at all. You just lay on a table. It's an X-ray, but it's a very, very low-dose X-ray. So the technician is unshielded. They just sit there and they can do the test. It takes about 5 minutes. And what that test tells us then is, in particular, what is the bone density of your spine and what is the bone density of your hips. Those are the areas we're most concerned with, because those are the areas that are most affected. And in the case of a hip, if you break it, that is the greatest morbidity and mortality. Really, it's probably about the greatest morbidity and mortality short of heart disease that an adult can experience. My own mother, who's 91 years old, and you'd think, you know, her being my mother, she wouldn't have a fracture, but she was unsteady and her judgment's not as good as it once was, and she broke her hip about 6 months ago. So I've seen this firsthand as she's entered a nursing home, and you know, her whole life situation has changed abruptly. And this happens to 250,000 Americans every year. And a lot of these people die. You know, about 25% of them die as a direct result of hip fracture. So we want to prevent all fractures, but in particular, hip fractures are the big issue. So you get the bone density test, and then what happens? So if your doctor decides that your bone density is lower than it should be, you may want to prescribe medications. The way we look at that is the diagnosis of osteoporosis is made when your bone density reading is negative 2.5 or lower. That negative 2.5 number, that's called a T-score. And what that number is actually a comparison of you, the patient, to a young woman, a young adult, 25 to 35 years of age, and it represents the determination of risk. So in other words, if your bone density reading is negative 2.5 or less, your risk is great enough that medication would be recommended. Okay, in other words, your risk of a fracture is so high that we would recommend you be treated. If you've lost bone but you're not quite at that degree, then it depends on your age, it depends on some other factors, but in some cases we would treat women and men before they get to that osteoporotic stage. So does that make sense? So let's say you're osteoporotic. Let's say you come in, and the first thing I do when you come in my office, apart from the pelvic exam and all that, we're not talking about that, but the first thing I would do is measure your height. So if you don't know, as an adult sitting here right now, if you don't know what your height is, if you're just thinking it's the same as it was in high school, that's something you may want to check. Most of us, as we grow, we lose height. This is normal, and up to an inch really is not a concern at all, because actually our joints get narrower. Our knees in particular, other joints get narrower, so it doesn't mean you've lost bone. But if you lose more than an inch, let's say you've lost 2.5 inches, and I have people think about what their height was in high school when they got their first driver's license. Most people remember that. Compare it to what you are today. If you've lost, say, 2.5 inches in height, that's bone loss. And what you'll see, if you look at somebody sideways, they probably have some kyphosis. Kyphosis is that curvature of the upper part of the spine, also called a dowager's hump. I don't know if we have a lot of dowagers around, but there's a lot of people, and men included, that begin to develop this hump. It develops very slowly, but it's not something that the chiropractor can fix. It's not something that's surgically correctable either. It's something that actually occurs. It's a disability. You know, you see people that can't even walk upright. They have to have a walker and they're bent over, and that's because of kyphosis, which is loss of bone from the spine. And really the only way to deal with that is to prevent it. So if we're seeing people that are losing bone from the spine, if their T-score is negative 2.5, you really want to get them on medication. So you might know a little bit about medications because you've heard this, you know, on TV. You've seen Sally Field. Sally Field, most people probably here are old enough to remember The Flying Nun. Sally Field and, you know, other things that she did. Great actress. But she's now a spokesperson for Actonel. And there are several drugs that are in use. So you're probably familiar with Actonel and Fosamax and Evista and Boniva. Those are the main drugs that are used. And those are oral agents, okay? And what we found is that in most cases, they do help, but they're not terribly effective. The problem with all those drugs is they're very poorly absorbed. It's about like swallowing a rock as far as absorption goes. Most of that drug, 99% of it, goes right through you and is not absorbed. That's why you have to take it, say Fosamax, you have to take this drug on an empty stomach, first thing in the morning with just water, no food, because otherwise the drug will not be absorbed at all. So best case scenario, you absorb about 1 to 2%. So the modern strategy, and what I've been doing lately, instead of using those oral agents, which possibly people in this room are taking right now, instead of using those agents, I'm going more to IV and what we call parenteral therapy, which means injectable drugs. Because they work better, they're more effective, and the real beauty of it is it's given at longer intervals. The best drug, I think, as opposed to using Fosamax or Actonel, is Reclast. Reclast is given intravenously once a year. It's covered by Medicare, one of the few drugs that is actually covered by Medicare Part B, the real Medicare, and it's very effective. So that's one of the strategies. Another strategy is there's another drug called Forteo, which I don't know if people have heard of. It's not a drug we use commonly, but actually Forteo builds up bone more quickly and more effectively than any other drug we're using. It's given by daily injection like insulin, and most people are on it for 2 years. So in general, if I have a woman who's just broken her hip and she's getting out of the hospital, the main concern I'm going to have is that she's going to refracture either that same side or more likely the other hip or somewhere else. You want to get her on the most effective therapy right away, and that's probably going to be Forteo for most people. It is an injection. It takes some education to learn how to use it, but it's quite effective, and that's the go-to drug for most people. So what'll happen then if your doctor decides that a medication is right for you, generally put you on something, hopefully you'll keep taking it, whatever it is, or follow their advice, and then go back every 2 years to get a repeat bone density to see how it's doing. If you're lucky enough to have good bones and your doctor does a bone density on you, let's say you're 60 years old, your bones are normal. Let's say your T-score is -1 or less, or it's in a good range. You never have to get another one. You don't have to keep going back. It's not like a mammogram. It's not like colonoscopy. It's not like other tests. So if your bones are good, chances are they're going to stay good. And we think that's genetics. We think it's probably in part dietary, your absorption of calcium and vitamin D. For lots of reasons, you don't have to go back ever again. So just to say a word about calcium and vitamin D, because this is something that's really confusing for a lot of people. In our diet, in our society, most of our calcium comes from dairy, either milk or cheese, things like that. There are people, of course, that can't tolerate dairy, that have lactose intolerance. They can get calcium from other sources. And Melissa Nickel is here, our dietitian, and she can talk about this too. But for most people, most of their calcium comes from dairy. What I do in my patient population is check vitamin D levels. What we find is that if your vitamin D level is low, which means less than 30, it should be 30 nanograms per mil or greater. If it's low, that's a real good marker for the possibility that you're either not absorbing calcium and vitamin D or you're not taking enough. So in general, I'll recommend for my patients with bone loss that they get 1,000 milligrams of calcium and at least 500 to 800 units of vitamin D a day. And generally, that's a combination of what you're getting in your diet plus one dose of whatever supplement you like. And there's a lot of different supplements. So there's Caltrate, there's Citracal. The kind I like are the chewable ones, although not everybody likes those. But they're chocolate flavored. They have all different flavors of chewables that contain calcium and vitamin D. The only side effect people complain about is constipation if they get too much. Now, there was recently information that people were concerned about that said if you get too much calcium, it might cause heart disease, or it might be bad for you. And this was a study where people were actually getting 3 to 4 times the recommended dose to try to make up for osteoporosis, and that is not what we're recommending at all. So these standard doses that are recommended by the American Dietary Association and others are really safe. I mean, in most people, unless you have kidney stones or some other disorder, that's going to be what your doctor would recommend. We also, of course, recommend you quit smoking. We recommend that if you're on steroids, that we follow you very closely for bone loss. There's special conditions that, increase our concern, but I'm talking in general for most people with bone loss. So the goal is prevention, okay? Number one is identifying people that are at risk and preventing it. But what happens if you have a fracture? So let's say you fall, and typically in a postmenopausal woman or an older gentleman, if you fall, the first bone you're going to break is your wrist. Because typically when you fall with an outstretched hand, you get what's called a Colles fracture. You break off the head of the radius. And that is an osteoporotic fracture, first and foremost. Now, it can occur in anybody. I mean, you could be 35 years old and fall and break a wrist, but it's much more likely to happen in somebody who's postmenopausal. That's just a bone that's at high risk. So if that bone breaks, we don't have to really do a lot of studies. We know why you're losing bone. It's because you're postmenopausal, and we know what to do about it. We really need to probably put you on some medication and keep you on something, at least for a time. And the reason is because if that bone's at risk, if you broke that bone, your other bones are too. And then we can do the study, and we should do a DEXA. That's important, but it doesn't take a rocket scientist to figure that out, that if you break one bone, you're likely to break others. What are the risks of these medicines? People worry about, taking medications because of risk. And I tell my patients, no matter what medication we choose, for whatever reason we choose it, it's always a trade-off. And that's something they never really explain. I mean, if you take Viagra or you take some other medication, it isn't like a magic formula. There's some trade-off. You're going to get a benefit from the medicine, but there's going to be a downside to it too. That only seems natural, and the more effective the medication is, probably the more enhanced the downside will be. So for example, if you take something for blood pressure, if it's really going to effectively lower your blood pressure, well, it may well affect other things as well. So this is no exception. So medications that affect your bone can and do have side effects. From taking an oral medication, the main side effect is going to be gastric upset, and patients complain of that. And people worry about bone loss in their jaw, which is called osteonecrosis of the jaw. However, this is very rare. So I get calls from dentists sometimes and patients that are contemplating dental work, and it sometimes is a big concern, but I can tell you it's very, very, very rare. So as a doctor, I talk to the dentist, talk to the patient. We can usually work around this. It is not a reason to worry about taking these medications. It's a reason to get your dental work done before you start the medication, possibly, but it's not something that you have to worry about. You can never take this medicine because you had a cavity or because you had a root canal. That's not the way it works. The other concern is from long-term use of these medications. People noticed that after a number of years, that fracture rates actually began to increase. And what happens in a few cases is the bones actually become more brittle. But that, again, is the exception to the rule. And again, we avoid this by following people closely. So what we're doing is putting people on drug. We're following them closely. If it looks like their bones are beginning to change or they've been on the drug long enough, then we stop it or we change it to something else to get around that side effect and that issue. So I guess what I'm saying is the benefits of these drugs outweigh the risks, and it's been estimated and actually been shown in some populations where they have socialized medicine and national health care services that you can actually lower fracture rates by 25%, or change the age of fracture to older patients. So you're protecting people from fractures longer and preventing fractures by identification and treatment. So that's something we hope to do a better job of. Medicine in general doesn't do a real good job of protecting our patients.
I'm Melissa Nickel. I'm the dietitian here at LBGYN. And there's obviously a lot of focus on diet in itself with just bone health that unfortunately is not just a look at, obviously the first focus would be prevention, but another focus would be where do we go from here? I always encourage women and men to evaluate their diet currently. Let's look at yesterday's diet. How much calcium, how much dairy did you intake yesterday, or how are you getting non-dairy calcium sources? I would recommend at least about 3 servings a day, and unfortunately, that seems to be a focus that is not there. Just as important as being a healthy body weight is bone health as well, too. Strength training is obviously encouraged as well. And unfortunately, we don't focus much on that as well. So putting those two focuses together. And as far as another common question I do get is alternative to milk sources and calcium. Actually, they're very similar in calcium sources when it comes to almond milk, rice milk, soy milk, things like that. The only differences you do see are some of those are sweetened, so they have a little more added sugar, added calories to it. But as far as the overall calcium content, they're about within 15 milligrams of each other per cup. So very similar. So those may be some alternatives that some people can try that are lactose intolerant, in addition to the darker leafy veggies, as well as fish is another one that's a good one to grab. Salmon and cod and things like that.